This is Michael Altos recording Opioids and Context-Sensitive Halftime, Part 3. Now we're moving on from our strong agonists to our partial agonists, now on to mixed agonist-antagonists. This is a little bit more complicated. These are substances that are still opioids. They're related to morphine, but they bind at multiple opioid receptors in different ways. Some of the classic examples are nalbuphine and butorphanol and buprenorphine. When these drugs are given together with a full agonist, you get an additive effect up to the maximum effect of the partial agonist. And we saw that already before. And so these can be used to prevent euphoria, the sort of competitive antagonism of the original full agonist. And we discussed this in the last section. Some people think that these drugs have a little bit less abuse potential than full or partial opioid receptor agonists. So let's see some examples of these drugs and try to understand these ideas a little bit more completely. The first drug we'll talk about is nalbuphine, which is called Nubane. This drug is actually a kappa receptor agonist and a mu receptor antagonist. It works about as well as morphine, actually, but it has a ceiling effect on its respiratory depression at about the level of 30 milligrams of morphine. And that's probably because of its mu receptor antagonism. You could actually reverse morphine-induced respiratory depression using Nubane without taking away all of their analgesia. So you can block their mu receptor, but still maintain some analgesia through their kappa receptor. The most common clinical use of Nubane is pruritus, itching that people get when they get intrathecal or epidural morphine or fentanyl. We use it a lot in our pregnant patients because there's less risk of respiratory depression. We can cut out some of their itching and still help them with their pain. If a patient is truly addicted to opioids, you could actually precipitate withdrawal in a patient who's getting Nubane by blocking that mu opioid receptor. Nubane itself has a pretty low abuse potential, and its elimination half-life is about 3 to 6 hours. An important drug that you should be aware of, because you will definitely see more and more of it, is buprenorphine, also called Buprenex. So this drug is kind of the opposite of Nubane. It's a partial mu receptor agonist and a kappa receptor antagonist. People take this drug as a pill, usually sublingually, so you avoid the first pass effect. And what's interesting about this drug is that it's 50 times more tightly bound to the mu receptor compared to morphine. So once you've given this drug, morphine will not be able to compete it away except at extremely high doses. And it works for such a long time because it dissociates very slowly from the receptors. The drug also can't be antagonized very well with naloxone for the same reason. It binds so tightly to that mu receptor that nothing else can really compete it away. Buprenorphine has been used for patients who have chronic pain. It's been used for patients who have opioid dependence and have a history of opioid abuse. It binds much more strongly to the receptors than other opioids do. And actually other opioids, if they want to take heroin or something, or their OxyContin, it won't give them any effect because the buprenorphine has bound up those receptors. This can be an issue when you have a patient who has real pain, like a surgical patient, and we're going to speak about that in just a moment. Suboxone is actually buprenorphine plus naloxone mixed together. And the reason they do this is because theoretically you could take your buprenorphine and you could inject it, grind it up and dissolve it and inject it and get a little bit of a high from the rush of the injected buprenorphine. So for that, what they did is they added naloxone to it. And the naloxone will prevent people from getting that high. But if you take it orally, naloxone isn't absorbed through the gut. And so the naloxone stays in the gut, the buprenorphine is absorbed, and then they take it properly. Now, what do we do about patients who come in while they're taking Suboxone? So if the procedure isn't going to cause very much pain, then we don't have to worry about it. Or suppose the whole thing can be done with local anesthetics. So that's fine, but otherwise we're going to have a patient who's taking buprenorphine, and opioids are not going to work on this patient, and they are going to have out-of-control pain. So we really have 4 choices. One is, if we can anticipate, we can wean them off the buprenorphine at least 4 days in advance. Or instead of just weaning them, we could switch them to another drug, like methadone or even just to morphine. Anything to prevent them from going into withdrawal, but also something that will occupy those opioid binding sites and not be as competitively attached to them. If you don't do any of those things, then you're going to need to be prepared to give very large doses of opioids in the post-op period. The patient may need additional monitoring or nursing care or even ICU admission for the megadoses of morphine or Dilaudid that they'll need to control their pain. Elective cases on patients who are taking buprenorphine should probably be canceled if one of these accommodations hasn't been set up ahead of time. Now, we've alluded to naloxone or Narcan a few times, and now let's talk about it for a moment. Narcan is an opioid antagonist. It's a pure antagonist at the mu and the kappa and the delta receptors. It can reverse even endogenous opioids acting at those sites, so it completely blocks those receptors. Now, you need to give Narcan carefully, because if you blast it in really fast, people will get sudden severe pain. They can get hypertension or tachycardia or even pulmonary edema. If a patient is addicted to opioids, it can precipitate withdrawal. And so for that reason, the way we dose this drug in our world is we take a vial, which is 400 micrograms, 0.4 milligrams, and we dilute it down to 10 milliliters. And then we give 1 or 2 milliliter. We give like about 1 milliliter, which is 0.04 milligrams, 40 micrograms every 1 to 2 minutes. So we don't blast in the whole vial. We give it a tenth at a time, maybe even less, and then watch the patient. The drug acts very, very quickly, and within a minute or so, you'll know if they need a second dose or not. Remember that Narcan doesn't last very long, only maybe 20 or 30 minutes. So if your patient is overdosed on a drug that lasts 3 hours, you may need to redose your Narcan or put them on a Narcan infusion. Take a moment to think about any questions you may have about what we've covered so far. Now we're going to switch gears and talk about a very important concept that applies not just to opioids, but to all IV anesthetics. That concept is called context-sensitive halftime. And what that means, well, halftime we know is the amount of time for drug concentration in the central compartment to decrease by 50%. So that's halftime. The context means the duration of the infusion prior to stopping it. Let's understand what this means. If I look at a drug, this axis tells me how long will it take for the plasma concentration of that drug to drop by 50%. So let's say fentanyl. I run a fentanyl infusion, and I say it's going to take 10 minutes for the drug level to drop by 50%. That occurs when I've run my fentanyl infusion for 30 minutes. But suppose I run my fentanyl infusion for only 1 minute. Well, then it's not going to take 10 minutes for the plasma levels to drop by half. It'll take much less time. If I run the infusion instead for 2 hours, well, suddenly it's going to take almost 30 minutes for plasma levels to drop by 50%. And if I run my infusion for 3 hours, it's going to take 60 minutes for plasma levels to drop by 50%. So what we are seeing here is the halftime plotted on this axis as a function of the context, the duration of infusion, plotted on this axis. And each drug has its own different context-sensitive halftime. So you can see fentanyl, which is very lipid-soluble, builds up over time as the context, as the duration of infusion increases, and it takes longer and longer to get rid of this drug from the plasma, because every time you metabolize some of it, more drug comes from the peripheral compartment back into the plasma. Compare that with remifentanil, which is metabolized almost instantly, and regardless of how long you run that medication, it's always going to take just a few minutes for the remifentanil concentration to drop by 50%. And we can do this not just with opioids, but with other IV medications as well, and each of them has a context-sensitive halftime. Now, when we talk about context-sensitive halftime, like we said, what we're describing is this phenomenon where the drug that's in the peripheral compartments starts reinfusing back into the central compartment. So the more drug that builds up, usually because it's a lipid-soluble drug, the higher the context-sensitive half-time is going to be. And you can't really calculate this, you can't extrapolate it. It's something that needs to be measured experimentally. And you should be aware that the 50% context-sensitive half-time might not be the most clinically meaningful. So for example, here's that curve of fentanyl again that we saw before, and that's how long it takes fentanyl to drop by 50%. Now, how long does it take fentanyl to drop just by 25%? Well, obviously it's not going to take as long, even for long-running infusions. But suppose I want my patient to breathe, and I need my fentanyl levels to drop by 75%. Well, then I might be looking at a curve that's more like this, and suddenly long infusions can have a very, very long context-sensitive decrement time, and I would need to turn those infusions off well in advance of emergence from anesthesia. On the other hand, remifentanil, which has these wonderful pharmacokinetics, has flat curves almost at any decrement. So even if you want to get rid of 75% of the remifentanil, obviously it will take longer. It'll take 8 minutes instead of 2. But regardless of how long your context is, your duration of infusion, that context-sensitive decrement time doesn't really change. Just to clarify this one more time, this effect, known as context-sensitive half-time, becomes more pronounced as you're trying to clear out a larger percentage of the drug. So if you just want to get rid of 20% of the plasma level of fentanyl, that's not going to be very difficult, even if you run your infusion for a long time. But if you want to get rid of 80% of the drug, the difference is really very significant. And here we are seeing that concept one more time, just looking at fentanyl, alfentanil, and sufentanil. And all of these have a relatively flat shape. The fentanyl has a little bit of a bump when you're just trying to get rid of 20% of the drug. But when you're trying to get rid of 80% of the drug, you can see how fentanyl is really not a very desirable drug to run for many hours, whereas alfentanil or even sufentanil are much better choices. We'll stop here. If you have any questions, please let me know or bring them to class. And this concludes the section on opioids and context-sensitive half-time.